Good morning, everyone. This is Mary Gregory with MAS Coding Solution. Welcome to our classroom today. Today we're going to be talking about Z coding. We're going to be talking about preparing for the CCS. This will also help you with the CPC as well. We're going to be talking about a very specific segment of codes. And there's a lot of misconception around Z code coding. And so today we want to dispel some of those misconceptions. One of the biggest myths out there is that Z codes can never be a principal diagnosis or a first listed diagnosis. A part of that is true and a part of that is not true. And I think the way that this got started is because there are some insurance carriers that do not want Z codes as principal diagnosis. Now, when I said principal diagnosis, I'm talking about from an inpatient setting. When I said primary diagnosis, I'm talking about an outpatient setting. And really and truly, they are the same. It's just that for whatever reason, inpatient is referred to as a principal, primary is referred to outpatient. But at the end of the day, your role as a coder is to know what truly caused that patient to seek health care. And we going to code based on, of course, ultimately the findings that the physician had. So there can be times a patient can come in, and on one of the videos, I think the last one we did, we're talking about admitted diagnosis versus a primary diagnosis or a principal. There's a lot of time your admitted diagnosis will not be your final diagnosis. And that's why it's important for you to understand the coding guidelines. It's important for you to know how to marry your coding guidelines with your documentation. So today we're going to be talking about, if you had an ICD-10 CM book, it is actually chapter 21, the official coding. It's the chapter 21 in your book. And of course, if you're looking at your official coding and reporting guidelines, it's going to say chapter 21 as well. That chapter talks about the factors that influence health care. So there are other factors that causes a patient to come to a facility other than just being sick. And that's why there are going to be times you're going to have Z codes as principal diagnoses. And these they're broken out in categories for you. And so one of the categories is like history of. When a patient have a history of something, that means they no longer have that disease process. But they may need some type of follow-up on that. And sometimes the history of too, we use those codes to convey more information about a patient. So let's take for instance of if a patient come into the facility or ER and they have an abdominal pain. That ER, the history of that patient, and let's say the patient had colon cancer, and they had the resection done. Resection means excision removal. So what happened is when that patient come into the ED with abdominal pain and they tell the physician that they have a history of colon cancer, now the physician going to have to think a different way because they don't know if this is a recurrence. They don't know if this history of colon cancer is causing another problem, and it may have nothing to do with it at all. But that also helped the ER physician to know this, that is, especially if they had part of the colon removed, they had the cancer in it. Now the ER physician can eliminate certain diagnoses based on the fact that that patient have had that part of the colon removed. When we are coding, we are always trying to tell a story. And it's our job to tell that story to the best of our ability. Sometimes we can make that story very exciting with our codes. And sometimes it can be very boring with our codes. So a history of is where a patient have had a condition, but they no longer have that condition. Then we talk about, I'm going to skip around a little bit because it's two that I specifically want to focus in on. We talk about follow-up. Sometime a patient will have a condition. It's not necessarily eradicated, meaning removed, and they may have to come in for follow-up. Sometimes they may have had their condition removed and they want to follow these patients up. Sometimes you see the word surveillance being used. And we probably hear that a lot in our culture now, surveillance. But it means the same thing as follow-up. That means that the patient has something done for that condition. It could have been surgery, they could have been on chemotherapy if they had cancer, and now they're surveilling that patient. Bone marrow transplants. When patients have transplants, they have a lot of follow-up because they have to make sure that the transplant is not rejected. Then we have a code. We have a group, a Z code for aftercare. And aftercare covers situations where they have initially had some treatment done, but they're still needing some aftercare in that recovery phase. And you have to be careful with aftercare because, see, sometimes, like with cancer, we don't use aftercare code when a patient is currently receiving chemotherapy, radiation therapy, immunotherapy for that cancer. As long as they're receiving treatment for that cancer, then we have to code the cancer. And so that's why it's so important that you understand these guidelines and how to use them. You have codes for counseling. Maybe somebody just want to come in and they want to be counseled against about their diabetes, or that's a nutritional counseling going on. They may want to be counseled about, excuse me, some infertility. Sometimes women have infertility problems and or men, and they may go to a specialty that will talk to them and counsel them about infertility. And so you have codes for that. You also have codes for donor. Just recently I did a chart where the brother was a donor for his brother. His brother had some type of acute leukemia and needed a bone marrow. And so he was a donor. And we have codes for donors. We have codes also for what we call prophylactic removal. I don't really keep up with Hollywood, but I think this lady named Jolie something, I think she was married to Brad Pitt or something. Angelina Jolie, I think that's her name. Well, anyway, she had a double mastectomy done. And that was really prophylactic. She didn't have breast cancer, but what she had when she had these very specific types of I'm gonna use, I don't want to say organism. It'll come to me. When she was tested, she had these antibodies in her body that could indicate that she was more at risk to get breast cancer. And because of that, she made a decision to have her breast prophylactically removed. And so when you want to use that word prophylactic removal of an organ, that patient can absolutely have no signs of actually having the disease. She was just a carrier in her cells. She was a carrier of this particular morphological thing that carry a cell or organism that they may see a lot in women that have breast cancer. And so she prophylactically wanted those removed. It's very important that you do understand that there are going to be times when a Z code cannot be principal. And they are listed out for you in your book. Your book will have some type of symbol that would tell you that these are codes that are generally they not to be principal diagnosis. And when you see some of these, it makes sense that these would not be principal diagnosis. A lot of times, nobody come to the ER or go to their doctor because they have a history of colon cancer. Yes, they have a history, but when they go to the doctor, they're going to be going for their follow-up. See? And so you would do your follow-up code. Of course, all things being equal. Now, I'm not talking about the patient that is still on chemo, radiation, or immunotherapy, because those patients are coded differently. I'm talking about patients that have, hey, they had a resection done, they then had chemo done, and now they're just being followed up. I was reading an article recently about breast cancer, and the article was about why is it that we, in America anyway, a lot of women still choose to have a mastectomy. That means removal of the breast, versus just having that lumpectomy done, where they just go in and they just cut out that little small area of cancer. And so the study was quite surprising, because they thought with the advent of things getting so much better in healthcare, and they was talking about how 20 years ago a total mastectomy was the way to go if someone had breast cancer, because they felt like the survival rate would be greater. Well, what they found out when someone discovered maybe we can just remove this little small lump of cancerous cell and we will not have to remove the entire breast. And a lumpectomy, sometimes when you code that out in CPT, it actually says partial mastectomy. So a partial mastectomy means that you're just getting the tissue out that need to come out. But the study found that a lot of women still preferred a mastectomy. And so there was a lot of writing about an opinion as to why is that. So you will find sometime that certain, I guess, older treatment still is relevant today. But anyway, so if this lady have had her mastectomy, I had a friend that had breast cancer. So she had the lumpectomy. She had the small area in her breast removed. She had chemotherapy. And then she had radiation therapy. Now, she's been cancer-free for the last 5 years. So whenever she go to her oncologist, she is going for a follow-up, because she is considered to be cancer-free. And so sometimes too, what we struggle with in doing follow-up is how long, or what is the time frame for knowing that someone is cancer-free. Okay, so anyway, didn't want to get off on that. What I really want to talk to you and kind of focus in on is this word screening. Screening. It's a lot of confusion concerning screening. And you may have a test question or two on your CCS and or your CPC. So you may have a test question about it. What is screening? And the problem is this. We are struggling with a screening examination versus a diagnostic examination. People are struggling with it. The screening, according to our ICD-10 official coding guideline, screening is the testing for a disease or a disease precursor in seemingly well individuals, so that early detection and treatment can be provided for those who test positive for the disease. A screening, in the simplest word, means this: that patient have no evidence of having that disease. They have no signs. They have no symptoms. But they want to be screened because it's a possibility. Now, what makes them have that possibility? Well, take a lady, for instance. They said that we should have, and you can check me out, I can't remember the exact age, but I'll just say 50. At 50, you should have a screening mammogram. Just because screening mammogram have been used as an early detection tool for breast cancer. If you're in a family where the mom had breast cancer, the aunt had breast cancer, the cousin had breast cancer, you need to be screened, because you may have a greater chance of having that and you don't even know it. So the screening helps detect something that you don't know you have. And this is very interesting for you guys out there. Just in case nobody ever told you this. Guys, men, gentlemen, boys, if your mom had breast cancer, if your grandmother had breast cancer, you can have breast cancer. See, a lot of times we don't talk about men having breast cancer, but you can. And the other thing you have to think about too, men, is this. You get married, you have children, you have daughters. Your daughter may have a greater chance of having breast cancer because your mom had it. Because remember, you got some of your mom DNA in you. And you're going to pass it on to your daughter and your son. Okay, so screening means that you have never, ever had a problem with that disease. Ever. And you're going to be screened. Diagnostic means you got a problem. So you can't be a screening. So if that lady come in, she said, oh, I feel a lump in my breast. Even when they give her mammogram, she's a diagnostic mammogram. She's not a screening. She got a lump in her breast. She got pain in her breast. She got a discharge coming from the breast. So that's a diagnostic. See. Colon cancer. Colorectal screening, as we like to call it. Oh my gosh, did we get that wrong? Once again, our government has set it up where certain screening, you don't have to pay for it. You go to your doctor, they say we're going to screen you. You don't have a copay, you don't have a deductible. It is free. And that's why we have to code it correctly. So when somebody come in for a screening, colonoscopy, they can have absolutely no problem. They can't have abdominal pain. They cannot have blood in the stool. Sometimes people go even so far as to say you can't even have a problem with constipation. If they have a change in bowel habits, we actually got a code for that. When that happens, when the physician document that, that's a diagnostic. But what the problem is, the patient will come in with a complaint. And the physician will say, being a great physician that they are, they'll say, well, have you ever had a screening colonoscopy? And the patient said, no, I haven't. He said, well, we need to set you up for one. And so the physician will write abdominal pain for your diagnosis, and then he'll write screening colonoscopy. That's where the trouble begins. Because if you got abdominal pain, you cannot be a screening colonoscopy. You're a diagnostic. The other problem with all this is that Medicare is the only carrier or payer that got very specific codes that says screening. Nobody else does. So the problem that we have with the Blue Cross Blue Shield patient or United Healthcare patient is this. That 45378 CPT code that you use for colonoscopy, it is used for a screening colonoscopy or a diagnostic. And therein lies the problem. If your patient is a Medicare patient, I brought this up, and let me see, I think that you got some G codes. Medicare actually got G codes that says you are being screened for colorectal cancer. So when my Medicare patients come in and the physician documents screening, I'm going to have my screening Z code. It's my primary diagnosis. I'm going to have a G code for my procedure code. And I don't even use 45378 on those people. And but when Blue Cross Blue Shield come in, I'm going to have a Z code for my diagnosis, but guess what? I'm going to have a 45378 as my screening code on a Blue Cross Blue Shield. Now, the way you can get around that is my CPT has a modifier called 33. And so you'll put the modifier 33 on somebody that's truly a screening. Because if the same Blue Cross Blue Shield patient came in with abdominal pain and they did a colonoscopy and he called it a diagnostic, it's still 45378. So therein lies the problem. As we get ready to close today, we're going to be talking a little bit about the Medicare G codes. Medicare is the only payer that have very specific codes that identify screening as a procedural. We have a screening diagnosis code, and we use that on Medicare, commercial, doesn't matter. The problem comes in when you have a commercial patient, Blue Cross Blue Shield, United Healthcare, those type of entities, when that patient have a screening colonoscopy, the CPT code is 45378, which is a colonoscopy. The problem is that 45378 is used also for a diagnostic. Remember, if a patient come in and have abdominal pain, blood in the stool, rectal bleeding, any of that, that patient have a diagnosis, so now they're diagnostic. And so the physician may write that the patient is going to have a colonoscopy, or they say screening. But see, once you as the coder have to know the rules, and you have to talk with your physician. If that patient is having abdominal pain, blood in the stool, change in stool habits, that is not a screening. It becomes a diagnostic. And you have to use the code 45378 because they're Blue Cross Blue Shield. Now, some insurance companies do use Medicare G codes, and I'll talk to you in a little bit about them. But you'll have to find that out. So let's say you got a Blue Cross Blue Shield patient, they got abdominal pain, and now they need a colonoscopy. If the physician writes screening colonoscopy, they can't be a screening. But the problem come in because 45378, the CPT code that you have to use, is used for a screening or a diagnostic. So if your patient have abdominal pain, your code going to be 45378. If your patient come in for a screening and they Blue Cross Blue Shield, and I'm just using this as an example, it's not set in stone. If you're out there working, you may find that Blue Cross Blue Shield will use the G code. We're just talking about this today as an example. And so my patient come in for, quote, a screening colonoscopy, and they Blue Cross Blue Shield, and guess what happened? You go to CPT, there's no code that says screening colonoscopy. You're going to use 45378. Well, what you're going to have to do, because the law of the land said that when you have a screening colonoscopy, you do not have to pay that deductible and copay. You're going to put a modifier 33 on that case. Say, on the 45378, you can use a modifier 33. When you have a Medicare patient, Medicare has very specific G codes that says that you are a screening. So when my Medicare patient come in, I'm going to have the appropriate screening code, and I'm also going to have a Medicare G code. What happens sometimes, though, is my Medicare patient will come in for the screening, and they'll find that they have polyps. When they find that the patient have polyps, I cannot use my G screening code. Now I got to use the therapeutic code. That could be a 45384, it could be a 45385, it could be a 45380, depending on how they remove the polyp. Now, I got to let Medicare know that this patient is no longer a screening, but a diagnostic, a therapeutic. But that Medicare patient cannot be charged for that deductible of 20%. So how do I identify that for Medicare? I identify that for Medicare by putting modifier PT. That stands for Paul and Tom. So modifier PT will either go on my 45380 or 45384 or 45385. I put that PT modifier on that CPT code. What that does is when that claim go into Medicare, Medicare will see that my diagnosis code was a Z code for screening. They're going to see that I have a D, whatever, D as in dog, code for my polyp. And they're going to see that I have a 45384 with the modifier PT. that stops right there and say, oh, okay, this patient started out as a screening, now they are a diagnostic, and they are not going to have to pay any copay or meet any deductible on that. And I could, once again, with your Blue Cross Blue Shield patients, if they start out as a screening and they have a polyp removed, you can put on their code 45384, whatever it may be, you're going to put modifier 33 on that one. But you have to be guided by the carrier. Sometimes, like I said, some carriers use Medicare codes, those HCPCS level 2 codes that can be strictly for Medicare. Some payers choose to use them as well. And so you'll have to find out what the payer wants. But when you're taking your CCS or CCSP or CPC, all of those, what's going to happen is if you get that question, they really want to know if you know how to code that screening. They really want to know, do you know how to code a diagnostic? So they're going to be looking for that in your answer. So always remember, once a patient starts out as a screening, always use your screening code first. And that's the same thing when you have a screening mammogram. If that patient come in with absolutely no signs and symptoms, and they find a micro classification, use the Z code first, code your micro classification second. Well, it's been great today. I thoroughly hope you enjoyed this lesson today, and I hope you are very successful on your CCS or CCSP or CPC or CRC. It's so many different credentials out there, but I'm a believer that you always need a core credential, the core, and that could be your CCS, that could be a CPC, that could be a CCSP, because if you get the core, you're going to be doing good. Well, this is Mary. I'm signing off for today. We got a beautiful day here in Charlotte, North Carolina. I look forward to putting some stuff together for the future so that you all can come visit me here in Charlotte, North Carolina. Don't forget to follow us on Facebook and LinkedIn. The YouTubes, we got many YouTube's videos. Feel free to go back and review those. And until we meet again in the future, take care and have a great day.